Hello, my name is Sean Park. I'm a prosthetic urologist who's practicing in Seoul, South Korea. I was recently invited to the UCI online conference. It was a great honor and joy, even though I was not there on site. When I first joined the UCI meeting, invited by Faisal Yafi, who is a course director at the UCI Men's Health Center. It was before the COVID, around 3 or 4 years ago. It was on-site meetings, and I had the privilege to go over there and join the meeting in person. Back then, they had a cadaver lab and all those courses. It was a wonderful meeting, but still, it was like a regional meeting. But since the COVID happened, and Dr. Yafi is such a brilliant guy, he was able to expand the meeting exponentially. So he brought in all those guys from Korea, Germany, and most of the countries. And this year there was more than 60 faculties, and there were 1,200 meeting participants, which is a huge number for doctors. Meeting for the doctors. So this time they invited me to talk about the subcoronal approach, which is one of the things I happen to do, and with the penile implant surgery. Since I have been doing the subcoronal approach for the past about 7 or 8 years, and I have now well over 1,000 cases with the subcoronal approach experiences. Around 5 years ago, there was a paper analyzed about the risk factor of the chalazion necrosis. For those who don't know, chalazion necrosis is one of the most dreaded complications after the penile implant surgery. And at that article, one of the risk factors analyzed was the subcoronal approach. But almost all the cases on that paper was done the sliding technique as well. So when someone is trying to do the sliding technique, he should do the subcoronal approach at the same time. So it is hard to say whether the subcoronal approach itself or the sliding technique itself is the cause or combined. Nobody knows about it. But my case, I did no case of the sliding technique. And when that paper was presented, I had almost over 500 cases of the subcoronal approach. So last SMSNA meeting, I submitted an abstract talking about my experiences about 898 patients who undergone the so-called simple subcoronal approach with an inflatable penile prosthesis. And none of them had any single chalazion necrosis or the ischemia. So at this meeting, I presented it again because I think it is important, as the paper I mentioned about. When that paper was presented after that, not many were willing to do the subcoronal approach anymore. So I happened to have the most experience with the subcoronal approach, and I had to present the data, because otherwise a subcoronal approach would have been pointed as a risk factor of the chalazion necrosis, which evidently is not. So one of the issues thrown to me was about the girth enhancement. Currently in the US, there are two methods became famous. One is penile implant, which is silicone prosthesis, and the other one is Paul's invention, the filler injection, like a power fill. Unlike in the US, South Korea has in mind almost epidemic of the girth enhancement that was started about 15 years ago in here. So I had an ample experience of girth enhancement. They asked me about the opinion about the girth enhancement, power fill injection or the silicone product. Technically, male enhancement is a very difficult job because no material can satisfactorily make the penis so-called enhanced, because penis is the only organ that changes its shape quite tremendously. And when it's changing its shape, it has a rigidity difference as well. So no material that they can stretch like that. Currently, mankind have, in my eyes, limited access of the proper material to do the male enhancement. We have to study the current materials, how to make it better, what's the limitation of it, what's the proper way of using it, and safety measures we have to do. And with that result, I believe that we can say that we are serving our patients in the right way. That's what the message I wanted to deliver, because we doctors should be prepared. If the patient asks for us, we should be able to tell them that with the scientifically and with the medically proven results, so that they can decide whether they are going to do it or not. Not telling them that this is right or wrong. No, that's not our job in my eyes. When it comes to aesthetic medicine or the quality of life medicine, doctors' jobs are not in the seat of the judgment. We should be able to work like a guide. Where do you want to go? I will tell you what the best way to get there. Once those kind of surgeries starts, nobody can stop it. It's quite interesting, isn't it? Because I never had a chance to think about the male instrument surgery in this way. But as I was invited to the meeting and they asked me such an interesting question, and that is the reason why I was able to think my practice differently. So yeah, I really think that, conferences and expose oneself to an intellectual meeting like this is very important to serve the patient better way.